much. Well, thank you very much for going out in the rain and coming here to listen to this lecture. As you noticed, yesterday I completely lost my voice, so I hope I will be able to make it to the last slide without going into silence, which might not be a good thing. So I'm going to be talking to you about a more important target organ of extracorporeal circulation and septic shock and states of inflammation, and that is the endothelium. I have declared interests. Most importantly, I'm involved in a company called Active Medical, which is exposing at this center just outside here regarding microcirculation. But the most important thing is I'm a physiologist. I'm not a clinical doctor. So my role here is to shake the cage, to maybe make you think in a different way about things which you're doing maybe automatically in routine clinical practice. So having said that, I would like to take you to this colorful gentleman who is Elias Mechnikov, a Ukrainian immunologist who, not far from Palermo, by the way, on a summer holiday, discovered phagocytosis. He was considered the father of immunology. And he already understood that the target of inflammatory states were the vessels, that's where the lesions occurred, and that was the target of shock. So, of course, now we know that actually what he called the vessels are now lined by endothelial cells, and endothelial cells are a key interface in between the circulation and the parenchymal cells responsible for organ function. They do the angiogenesis, the hemostasis, the blood pressure regulation, the transport function, the inflammation, and a lot more. And inside the endothelial cells, there are all sorts of mechanisms which translate what's going on in the circulation to what goes on in the tissue cells. So if you want to understand what goes wrong, this is the target cell that you have to be focusing on. And in all sorts of conditions, it will start to deteriorate. There is no, it's okay here or it's not bad. At the moment you put 100 mLs of fluid into a patient, the endothelial cells are unhappy. Because one of the main roles of the endothelial cells is to feel viscosity, is to feel shear stress. And that's the interaction of flow, hemodynamics, and vasotone autoregulation. But here you can see there are many such papers which have been produced. A normal homeostasis, we have the glycocalyx, which is a gel-like substance. And in that, there are all sorts of different molecules being expressed, much smaller in height than the thickness of the gel. So the adhesion molecules are like about 100 times smaller than the gel. So if the gel is there, the leukocytes don't see the leukocytes don't see the adhesion molecules. But as soon as the glycocalyx gets shed, like an oxidative stress, then you get rolling and sticking and all the bad things that we know happens in states of inflammation. So the endothelial cell is really a very interesting cell, and we should consider it as a target for different therapeutic interventions. And this was a paper we wrote together with Professor Vincent and Peter Pickers recently, looking at all the different phenotypes of the endothelial cells and what possible interventions could help to protect the endothelial cells or to actually cure them. But we must take, certainly from a physiological point of view, of course, which is a more holistic approach to what we're talking about, one step back. And Hippocrates already said it, make a habit of two things to help. But let's first take a step back and not do harm. Let's start with that. And there's certainly a lot of things that happen in perioperative medicine and critical care which cause harm. Necessarily so, but one must be aware that every good side has a bad side. So if we look at fluids in themselves, we found out that indeed fluids cause glycocalyx degradation. Functionally, that basically means you are making the autoregulatory function less. One of the main reasons why the kidneys don't like fluids that much is this. However, glycocalyx in itself does not alter the vascular barrier. These are a number of studies that we did. If it happens immediately, if it happens for a longer period of time, then it does. So here we see that also in a clinical study, this is a study done by Nature Pure and colleagues, that the amount of fluids that you are given correlate to the amount of peripheral circulars heparin sulfate. So you can measure circulating shedding products of the glycocalyx, such as syndicant-1, heparin sulfate, and this at the moment is the gold standard. But also other things happen. During CRT, for example, not only do you see an upregulation of the glycocalyx shedding products, but also the adhesion molecules between the endothelial cells. And these are the true anchors and responsible for vascular barrier degradation and causing albumin leakage into the tissue cells. So these are VE cadherin, for example, is one, the main one, and you can measure this in plasma in a soluble form as a biomarker too, a much more precise biomarker for CRT. But also all the extracorporeal organ support systems that are there inducing shear stress changes. There's a big discussion in extracorporeal organ support, especially among the perfusionists, whether pulsatile or non-pulsatile pumps should be used, and the shear stress that pumps certainly have a negative effect on the endothelial cells. And here you can actually see it in cell cultures that that's the case, that these are in endothelial cells having anything. And if you look at the different types of left ventricular assist devices, one with pulsatile and one without pulsatile, there's also evidence to suggest that pulsatile, this is the HeartMate 3, causes a lot more problem with the autoregulation of the endothelial cells. So this is the reactive hyperemia index, which is a great and simple test. To see it, you basically give a cuff, and then with laser Doppler or some other measurement of peripheral circulation, you see if it goes up and then goes down again. If it goes up, it means that the cells, the vessels have dilated, endothelial cells, and once the oxygen comes back again, it regulates it back. That's the hyperemic response, a great clinical test which you can use. So let's now get back at the other side of the story, that once all the bad things have happened, what do you do? If we look at sepsis from a physiological point of view, everything that you can imagine happens at the same time. And every minute, the nature, the phenotype of the disease changes. Not only in terms of the expression of all of the different types of cytokines, but also the response of the body to the presence of those cytokines, causing, first of all, a positive effect, but on the long term, a negative effect. So because you don't know this, the only important parameter in critical care medicine is time on the x-axis. And everything is changing in time. But on top of all of this, every time an intervention is made, you give the steroids, the blood transfusion, the fluids, it changes the nature of the disease and the nature of the hit and the pathophysiology. As you start taking over from a therapeutic point of view, normally available physiological mechanisms there, and all of a sudden, lots of catecholamines, lots of fluids, and then, of course, it becomes an uncontrolled situation resulting in organ damage and organ failure, ultimately. So if we now pick out of all of those things, the cytokines, because the cytokines themselves are positive and negative, such as everything in medicine, oxygen, positive, negative, etc. So if we look at TNF, we definitely know that TNF levels increasing have a bad effect on the kidney. And the kidney is important because it really is the target organ and the real sufferer in all of these states. And if we look at the different cytokines, this is one study looking at the effect of cytokines in coronavirus disease, we see that the IL-6 of all of the cytokines is really the one which is the most sensitive associated with adverse outcome. So if we look at manipulating IL-6, we see that manipulating IL-6 is actually very, very good in saving the vascular barrier, as the barriers molecules here, the V adherents, for example, here, become much less if you block IL-6 than if you don't. And looking at the literature across there, you see more and more the idea coming that IL-6 really is the link between vascular pathologies and vascular disassembly. Here you see the VE cadherence resulting in leakage, edema, and all of the bad things that happen. And here again, we see that there are certain other like the C5a receptor, the complement activation too, is a key step in all of this. But the ultimate story, of course, is that you cannot get oxygen transport to the tissue. All of these cytokines are causing upregulation of proteinolysis, lipid peroxidation, and everything is going bad. So, what do we do? Do we do another multicentral trial in the New England Journal of Medicine, looking at some unpronounceable molecule that's supposed to solve sepsis? Haven't we done that now for the last 30 years? Nothing has come out. Zero. I would argue that there's not one multicentral trial that has been conducted in critical care medicine which has shown the benefit for patients. Not one. So it's time to leave that, and it's time to look at the physiology. And there certainly is no silver bullet. Maybe for very specific diseases like a clogged artery or something, but not for something as complex as sepsis. And we shouldn't go on a wild goose chase trying to find yet another molecule, expensive, even more complicated, nobody can pronounce. It's not going to happen. Insanity is doing the same thing over and over again and expecting different results. And that's certainly the case for trials. So let's go back again. What is really pushing, fueling this spiral of organ dysfunction leading to death? Well, it is all in the circulation, which is the connecting compartment between all the different organs. And this is a very nice paper, in my view, by Claudio Ronco and Ming Chiwala and John Kellam and Said, really saying that, we should have more control over the composition of blood if we want to make sure that things don't get out of hand. And one of the steps in all of that is the control of the cytokines. Now, why is that important? If you look at physiology in general, and this can be heart rate variability also, or cytokine storm, physiology needs a level of the different parameters within which it can either give too much or too little. That is regulation. If you are hitting the ceiling, you don't give normal physiology the room anymore to use its properties to alter any type of phenotype that you require. That's the situation with heart rate variability. If you don't have variability, you have a problem. The same as with cytokines. If we have a storm of cytokines and everything is maximum, you do not give the immune system the chance to correct that or to alter it. That's why the idea, which I find very appealing, is maybe not to find out TNF or interferon or any such thing, but just to chill the whole storm and make it a benign rainstorm maybe in which the cells have time to recuperate. And that's the basic philosophy behind hemoabsorption, and what we have done the most research on is the cytosorb. So if you now actually look at what cytosorb does, it takes out a lot of the cytokines, and you can see that if you do that, indeed, endothelial cells, especially seen in this study by Sasha David, these are the pre-cytokine removal. You see all of these adverse, no longer the junctions between the endothelial cells, but if you take it away, you see that cells look a lot happier. So looking again at the complicated scenario in the microcirculation, we can also say, just as we look at getting rid of all the cytokines, we can look also at the target organs as well. This microcirculation is a combination of many, many factors which finally make it it can be red blood cells, it can be endothelial cells, etc. The bottom line is the microcirculation has to transport oxygen to the cells, to the tissue cells. So we can look at the microcirculation. So we can do that underneath the tongue, and in great detail we can look at what is going on in the microcirculation during states of sepsis and particular types of therapy. So here we see, for example, I'm going to start with the myoglobin. It's an interesting compound. Myoglobin is really a very, very dangerous, as you well know, and rhabdomyolysis, I'm from Turkey, and in Turkey we had the earthquake recently in which many people died. Rhabdomyolysis was one of the main causes in the ischemia reperfusion in crush victims, which caused death. And here we can see very, very clearly that the redox state of the myoglobin is responsible for apoptosis and death of endothelial cells. So we did a study, a case study, using CytoSorb on rhabdomyolyzed victim. And this was done by Olcay Dilken in our unit. And it was a very interesting thing because it was how probably it works in practice and how important it is to really know what you expect from a particular technique. So we had a crush victim, an accident with a tractor. Both legs were lost, and patient had increasing levels of myoglobin. Now, around this, the EMEC filter was put in its place, and after a while, it was seen that it had no effect on myoglobin. However, we looked at the microcirculation, and it was relatively normal then. As myoglobin levels was going higher and higher, the attending clinician, Hilde de Geus, phoned us up and he says, well, why don't we try another filter, hemoabsorber, excuse me. But by that time, really the damage had been done. And that's what the microcirculation looked like below. It had come to a complete halt. If you then put in the CytoSorb, you see it was indeed very, very effective in reducing the myoglobin levels, but too late. So the question is, if the myoglobin had been put in earlier, it would have been much more effective. So this begs the question is that this might be a good way to look at it. So we did a case study, and we thought, well, if we just look at plugged vessels in the microcirculation as an indication that endothelial cells are not working well, as in this patient before, we added the CytoSorb, look at the lactate levels of this patient, vasopressor score very high, a very, very high SOFA score, and after 48 hours, the lactates were down, the vasopressor score was down, and if you look carefully, you can see that all of the vessels are being perfused. And Abele Donati in Ancona in Italy had found the same thing. You see here the reduction in IL-6, very, very messy statistics here, but if you look at the improvement in the microcirculation, very, very tight signal there showing that the improvement of the microcirculation was associated with the use of cytosorbent. So here we are now conducting, as we speak, a randomized controlled trial based on looking at the microcirculation as an indication for inclusion of CytoSorb. This is our wonderful team working in Erasmus Medical Center and also Haga Hospital, big teaching hospital in The Hague. And here already we can see some very, very preliminary results. This is one without a CytoSorb. You can see here very clearly all the plugged vessels. This is not good. We know from many studies that if you see this, these patients have a very bad prognosis with an outcome of around 50%. And this is one of the first ones that we did. You see the resolution of the plugged vessels resulting in a good perfusion of the microcirculation. Thank you for your attention.